All right, so this week we are starting the upper extremity, your first real foray into the kinesiology world, since all we've done at this point was review and introduce you to the topic. So we're going to start with an overview of the upper extremity, which will be your next exam, the entire upper extremity. So think shoulder, elbow, wrist, and hand. So just primarily looking at the upper extremity, everything including clavicle, scapula, from that point down is part of your appendicular skeleton, right? So it is primarily noted for movement, doesn't really offer protection because there's not really anything other than bone marrow inside the bones of your extremities. So it includes both upper and lower, but of course we're going to cover lower separately. And it also includes in the appendicular skeletal language the girdles. So of course for the upper extremity, that's going to be your shoulder girdle, which again is your clavicle, and your scapula, which we'll see as well. So appendicular skeleton, as we see, everything in fuchsia or non-purple pinkish color, right? So again, that's going to include what's called the shoulder or pectoral girdle. Either language is okay, clavicles and scapula, and then all of the bones of the upper limb. So remember, just to refresh your memory, arm only goes from elbow to shoulder. So that is specifically brachia in Latin. The forearm, which is only from elbow to wrist, aka antebrachium in Latin language. And then, of course, your hand and all the bones that are of your hand and your wrists, which is your carpals and your manus, which is the medical term that we learned for arm in our review session. So when we look at the upper limb, we are going to be covering a total of 32 bones. It's not as bad as it sounds because considering, that you have 15 of those, which are phalangeal bones, then we only have 17 other unique bones, so to speak. And again, metacarpals, we have 5. So there's a lot of repetition in there. They're divided into 2 separate regions, the pectoral and or shoulder girdle, which is only 2 bones, as I said, the clavicle and the scapula, and then what we call the free part, the other 30 bones that aren't directly attaching the appendicular skeleton to the axial skeleton. So that's why the pectoral girdle kind of gets its own name, because of the fact that it is the 2 bones that are physically attaching the appendicular skeleton to the axial skeleton. So again, just looking, our pectoral girdle would consist again of our clavicle here and our scapula. Anything involving the humerus, radius, ulna, carpal bones, metacarpal bones, or phalangeal bones would be part of that free part. So if we look at the upper limb, these are the breakdown. Pectoral girdle, as I said, 2 bones, scapula and clavicle. Free part, 30 bones, 1 humerus, 1 ulna, 1 radius. Again, when we say 32 bones, we're only talking about one side at a time. So really, you could say you have 64 bones, right? 8 carpals, 5 metacarpals, and 14 phalanges. So this is where you get your total for 30 on each side. All right. So the contribution of the upper extremity musculature to sports or skills is that everyday activities that involve visible movement, rowing, throwing, typing, running, doing push-ups, planks, pushing a grocery cart, all of those are going to be upper extremity obvious movement, right? So again, remember that your bones are not capable of pushing something. They're actually pulling an object from its origin. But they can push objects, right? So the bones themselves don't push, they pull, but they push objects, like pushing your arms to get out of a chair, carrying or lifting, pushing a shopping cart, right? Swimming, throwing, golfing, any of those involve our upper extremity movements. And of course, I think we would all agree it's a pretty important place. So we're going to start with the bone, aka the sternum. Now, technically speaking, your sternum, right, is not part of your appendicular skeleton, of course. I'm trying to go back here. So apparently it won't let me go back to that slide, but we were talking about the sternum. The reason we mention the sternum at all, even though it is not part of your appendicular skeleton, is that of course the 3 pieces of the sternum, manubrium, body, and xiphoid process, the manubrial portion of the sternum is a key place of attachment from that appendicular skeleton to the axial skeleton. If you remember from lab last week, we covered what was called the SC joint, or the sternoclavicular joint, where the sternal end of the clavicle, which is very much part of your appendicular skeleton, attaches to the axial skeleton at that manubrial notch to allow for the SC joint. So that's why that slide was there, and why I don't know, I can't back up when I'm recording for whatever reason, never knew that. So we're going to now start with the pectoral girdle. So again, pectoral, shoulder girdle, I don't care which name you use, interchangeable as far as I'm concerned. 2 bones, clavicle, aka your collarbone, number 1 most fractured bone in your body that we have data for. So again, I would argue that if we were able to record all evidence of a fracture, we would say that the coccyx is probably the most commonly fractured, but Again, clearly people don't go to the doctor when they break their coccyx, because what are we really going to do but say, yeah, you're right, it's broken. Clavicle, a little different, right? We need a little bit more stabilization. So we know the clavicle is an S-shaped bone, as I like to say in lab. It looks like two commas that were stuck together in the middle. The medial end, of course, we call the sternal end because it articulates with the manubrium of the sternum, the actual junction point of the appendicular and axial skeleton. And that, of course, makes that sternoclavicular joint. The lateral end, which we refer to as the acromial end, also makes up a joint that is palpable right at the bony part of your shoulder called the AC joint or the acromial clavicular joint, made between the acromial end of the clavicle and the acromion of the scapula or acromial process. So when we look at the clavicle, this should look familiar, right? We can see where we have a short convexity here and a much wider, longer convexity here. So again, 1 comma, 2 comma looks like 2 commas stuck together. Now, in terms of the acromial end, it's going to be more of a pinched, narrow end that's rougher and bumpier, while we're going to have a wider, flatter end to make our sternal end. You're also going to have closer to that medial side an impression or tuberosity-like area of where that first costal rib comes in contact with the clavicle just on the inferior portion. So this is looking at it superiorly from the top down. This is looking at it inferiorly from the bottom down. You can see where we've got this sort of groove on the inferior surface. Now, in terms of the pectoral girdle, the clavicle is convex in shape anteriorly near the sternal junction. So here, right, closer to that sternum, the clavicle is concave anteriorly on its lateral edge out here near the acromion. So convex here, concave over here, okay? All right, so the clavicle has many ligaments that attach. Normally, we would say that ligaments are going to add to the stability of a joint, and for the most part, they do a good job. Both the AC joint and SC joint are not commonly traumatically dislocated joints. They're repetitious breakdown through arthritis type repetitive movements, but of course there are clavicular injuries that can damage these ligamentous attachments. So basically we have the sternal end of the clavicle, so right up here close to where it meets the manubrium, just underneath. Again, you've got that first rib, so we've got what's called the costoclavicular ligament. Remember, that's the one that looks like a V, right? It kind of has two compartments in a V shape. The lateral most of the two is the trapezoidal line of the costoclavicular ligament. So that's one's closest to the acromial process. And the conoid tubercle, or the conoid portion of the clavicular ligament, is the medial of the two costoclavicular ligaments. And again, looking at the name costoclavicular tells us this is going to attach our first rib directly above it to the clavicle, to the inferior side of the clavicle. All right, so if we look at the muscles that then attach to the clavicle, it's a very common feature. I'm gonna have to get used to the fact that I can't go back to these slides. So anyways, 5 muscles that attach to the clavicle throughout the length of the clavicle. You've got the deltoid, which of course will be towards the lateral aspect. Pectoralis major, which is a chest muscle that will have a small insertional point towards the lateral end of the clavicle. Your trapezius, backside or posterior surface of the clavicle. Sternocleidomastoid, because that's going to come off the sternum right at the junction of the SC joint. And your subclavius muscle, which is just directly inferior the entire length of the clavicle. So sorry, I skipped over that one. I have to get used to the fact that when I record on PowerPoints, I can't go back. So one of the most common things we see clinically with clavicles, especially being the most fractured bone that we have incident records of, is what we call a fouche injury, a fall on an outstretched hand. So if I'm falling and I put my arm back to break my fall, or I'm falling forward and I'm trying to break my face not hitting the pavement, that is what we call a fall on an outstretched arm. And usually what happens is this is the impact point. All of the force gets transferred up your shoulder to the clavicle, and the clavicle takes the brunt of that direct impact or trauma. And right at the point where the two clavicle commas meet in the middle, so you have curve, right where those two curves meet is our junction point for where the fracture usually occurs. So it usually occurs midline, midpoint of the clavicle. Again, forces get generated from the upper limb, and basically this is the resulting place where all those forces are transferred. Therefore, most breaks are in the middle of the clavicle. Usually there's an obvious deformity. You'll see one end that's poking up through the skin, or very much obvious defect through the skin. So with the scapula, the other part of our pectoral girdle, everyday common language is, of course, shoulder blade. I've heard this called the angel wing bone, whatever works for you. It is overall a triangular shape. It has, of course, some notable features like the spine of your scapula, which is what we call the blade of the shoulder blade, right? So when you go like this and somebody's right in front of you doing that, and you see that little blade pop out, that's the spine of the scapula. Of course, at the end of the spine of the scapula, you have that little process called your acromion. In front of the acromion is another attachment process that comes off the anterior portion of the glenoid cavity, of course, called your coracoid process. And of course, then the little barely a depression on the lateral aspect of the scapula would be your glenoid cavity that makes up your glenohumeral joint along with the head of the humerus. The pectoral girdle scapula portion is a fairly long bone. It goes from ribs 2 through 7, so it covers in length almost all of your true ribs. Remember, it does not cover 1. Rib 1 is a very short superior rib in the back. So it doesn't have any overlapping with rib 1, but the rest of the true ribs 2 through 7 would all have that costal surface or anterior border of the scapula resting on the back sides or posterior surface of those 2 through 7 true ribs. So features of the scapula we should be able to kind of glaze over because, again, we're reinforcing these in lab. We've already talked about the spine. Though it's a key focal point as the blade, it's also a key divisional point. That above it would be supraspinous fossa, below it would be infraspinous fossa, supraspinatus muscle above, infraspinatus muscle below. Again, acromion is the one that's attached to the end of the spine of the scapula, and the coracoid process is anterior to the acromion. Again, if you look at the glenoid cavity as a divisional spot of that depression, the coracoid process would attach anteriorly or project anteriorly from the glenoid cavity. The acromial process would attach or protrude posteriorly of the glenoid cavity. So if we look at that again, here's our spine of our scapula. As I said, think of the mnemonic ass. Your ass is on the back. We have the acromion attached to the spine, and that's how we're spelling ass for our case. So again, up here, you're going to have that supraspinous fossa filled with the supraspinatus muscle. Below the spine of the scapula, you're going to have the infraspinous fossa and filled by the infraspinatus muscle. And if we look at that from the side view, here's that barely depression glenoid cavity. Again, anteriorly to it, coracoid process, posteriorly or postero-superior would be the acromion process. So in terms of pictures like this that I've included in notes, you want to be really comfortable both for lab and lecture of having very similar pictures on an exam, either type of exam, lecture, or lab, and being able to identify the common features. So if this was on a test and it said feature F is pointing to what structural feature, you would say hopefully inferior angle. If it was I, you'd say supraspinous fossa. If it was C, you would say, of course, the acromion. If it was B, you'd say the spine of the scapula. Superior angle is here. Supraspinous fossa is here. Of course, D would be pointing to your glenoid cavity, and then this little bump out on E would be your infraglenoid tuberosity. All right, so if we look at the fossil features of the scapula, again, the spine of the scapula is a pretty prime bone marking for dividing the supraspinous and infraspinous fossa from each other, which we just showed you. On the anterior side, or what you might hear called the costal surface of the scapula, you have the subscapular fossa. So it literally means below the scapula, because of course, anteriorly, it's going to be underneath the posterior aspect of the scapula. The scapular notch, or you might hear it called the suprascapular notch, is that little divital indentation, I can't talk today, sorry, above the spine of the scapula in a superior aspect of the supraspinous fossa. Again, use what you do know about the scapula to determine medial from lateral border. So medial is also called the vertebral border because, of course, it's the side that is closest to the vertebra, aka your spine. The lateral border we can alternately call the axillary border, and that is always going to be the same side as the glenoid cavity, which will anchor or bound your axilla, aka your armpit. Superior border, of course, what you guys would call the top edge of your scapula in anatomical position. And of course, superior angle, rounded upper portion, inferior angle, lower rounded portion, right? So those we've seen in lab and should be self-explanatory at this point. So again, I will point those out here. Of course, you see that this is an anterior view of your scapula. So the entire surface here that we're looking at as a depression is the subscapular fossa. If we wanted the name of this side, we could call this the anterior surface or costal surface of the scapula. Again, if you find your glenoid cavity, then you know that the same side of the glenoid cavity is going to be your lateral border or axillary border. Opposite side that's going to line up with the vertebra, medial or vertebral border. Again, here is our inferior angle. Here is our superior angle, which can also be divided into superolateral and superomedial angle. And then this entire straight line here going from the top of the superior angle down to that suprasternal notch, which is right here. That area in between is called our superior border. So notice that there is not a straight part on the inferior surface, though there is no inferior border, just so you don't get confused with that part. So again, if you had something to label like this in a test, M would be pointing to that sternal or suprasternal notch, or suprascapular notch, sorry. Scapular or suprascapular notch. L would be pointing to, and now it depends on what it would ask you. If it's asking you for the depression, it would be pointing to the subscapular fossa. Again, now notice it doesn't say anterior here, but I can see here's the glenoid cavity, here's the coracoid process, and here is the acromion. So if I can tell which one is which here, then I would know that this is the anterior surface, and of course K is pointing to your glenoid cavity. So in terms of the scapula, the coracoid process, which is the anterior of the two processes, as we've mentioned, has a specific significance for being the attachment point of a lot of shoulder-related muscles, not necessarily the sits muscles, not necessarily our rotator cuff muscles, but important muscles like biceps brachii brevis, so the short head tendon of the bicep brachii, which of course is our anterior arm bone here. The coracobrachialis muscle, which is a muscle that goes down along the arm and inserts onto the coracoid process. Pec minor, which of course is deep to pec major, and it has a singular attachment point at the coracoid process as well. Now, looking at the humerus, it is the longest, largest bone of the upper extremity, so not of the body as a whole, that belongs to the femur, but it's the longest, largest bone of the upper extremity free portion. It has a proximal head-shaped end, right, which is going to articulate with the glenoid cavity of the scapula to form our shoulder joint, which we clinically call the glenohumeral joint. And distally, the end of the humerus will make the elbow joint with formation or articulation with both the radius and the ulna. Of course, radius being on the lateral side in anatomical position and ulna along our medial side. Now, in terms of the surface features for the humerus, again, these should jive with what we've been learning in lab, so I'm not going to expect you to visualize all this now as we've seen it, and we'll look at some example pictures. But again, the head of the humerus has two unequal sized projections. Those are called my greater and lesser tubercle. They are separated by, as I call them in lab, the ditch called the intertubercular groove or sulcus. You might also hear it called the bicipital groove, because that is where the bicipital tendon of the long head of biceps brachii will run through, and that is where the tendon is located. So again, always look for that ditch, and then compare the two sides of the ditch. One side should look larger and rounder, and one side should look lesser and lower. So greater tubercle, lesser tubercle. Now, in terms of the features for the surface of the humerus, remember the humerus is one of the bones, the only bone that has two necks instead of one. So it has that anatomical neck, which is the area just around the depression that is the end of the head. And then the surgical neck is just below the proximal epiphysis. And again, named because that's a common site of fracture if you're going to fracture a humerus. Midshaft, if we slide down anteriorly on the anterior surface, just below the surgical neck, you're going to feel a roughened area with your finger called the deltoid tuberosity. Of course, that is where the deltoid tendon for the deltoid muscle, which is your shoulder cap muscle here, comes down and attaches to that point. So every time I move my arm, there's friction rub there that creates the tuberosity formation. At the distal end of the humerus, you've got the capitulum, which is going to be along the radial side, and the trochlea, which is along the medial side. So remember our mnemonic for THC, the active ingredient in marijuana, trochlea on the same side as the head with the coronoid fossa. So if you remember that those three go together. Capitulum, remember caput in Latin means miniature head or little head. So it looks like a miniature version of the humeral head, and trochlea is the one that looks like a spool of thread. Now, in terms of the little indentations at the bottom, on the anterior side, you've got two smaller depressions at the distal end. On the back side or posterior side, you've got a rather large depression. So the large depression on the posterior side of the distal end of the humerus, that's our olecranon fossa. That is there to accept the olecranon process of the ulna. And then on the front side, opposite the olecranon fossa, you've got the coronoid fossa that's just above the trochlea. It's the larger of the two anterior depressions. The smaller of the two, if you remember, is the radial fossa. So the coronoid fossa is going to accept the coronoid process from the ulna in elbow flexion. And then, of course, outside of the trochlea and the capitulum, you have two lateral-most depressions, side-most depressions, which are your medial and lateral epicondyles. So they're just slightly superior and more to the side in terms of reference of the capitulum than the trochlea. So next, if we look at, again, some imitational drawings that you might see on a test variety, again, if I were looking at this, A is pointing to the head. I can spy my little intertubercular groove or sulcus, what E is pointing to here. So if I compare the two sides, you can see that F is going to be your larger side, greater tubercle. D would be your lesser tubercle. G is going to indicate your G is going to indicate your continuation of that intertubercular groove. I is pointing here towards our deltoid tuberosity. Spiral groove or radial groove is what Q is pointing to here. Notice this is on the posterior surface because I see the large depression, which is the olecranon fossa. L would be pointing to same side as the head, so medial epicondyle. Now here you can see the trochlea, capitulum, and a very small bump out for the medial epicondyle. But if we look at the anterior surface, again, we can see those things labeled. N would be referencing your capitulum. M would be referencing our trochlea. J is now referencing the opposite side of the head, so lateral epicondyle. O is referencing our little radial fossa above, our coronoid fossa above the trochlea. The little fossa that was not labeled that would be right here would be your radial fossa, and K is not a feature that you have to know. So if we put this all together, we can see the front and back anterior and posterior aspects of these bones articulating. Again, what we call quintessentially that shoulder joint is right here at the head of the humerus, forming with the glenoid cavity to make our glenohumeral joint. You can see nice representation of greater and lesser tubercle with that bicipital or intertubercular groove between them. And of course, it is a joint that is known for lots of movement, thus not a lot of stability. So the ulna, which are, again, the medial of the two forearm bones in anatomical position. So again, always remember pinky, something stinks, PU, right? So pinky ulna, same side. It is going to have features like the olecranon. You can also call this the olecranon process. So if we're looking at the proximal end of the ulna that kind of looks like a wrench, it's the top portion of that wrench. Below it, the bottom lip of Pac-Man, or the bottom portion of the wrench, is your coronoid process. And just in between those two structures, we have our trochlear notch. And again, that is what it's going to articulate around the trochlea of the humerus. And at the distal end of the ulna is where you'll find the styloid process, that little projection off of the distal end of the ulna. And again, remember, if you have styloid process on any exam, to put styloid process of the ulna, because there is also a styloid process of the radius. All right, so when we further look at the ulna here, you're going to notice that the ulna, of course, being on the medial side of the forearm, but the lateral side of the ulna. So ulna is the medial side forearm bone, but we're talking about the lateral aspect of the ulna is going to be your interosseous margin. Remember, that's always going to be on the same side as the radial notch, which has to meet up with the radius. And the interosseous margin is formed between the radius and the ulna. Of course, at the distal end, so up towards the wrist end, you have the head of the ulna. That's where you'll find that styloid process. You're also going to find the radial notch, as we just said. That's going to be on the proximal end, nearest the side facing the radius, which is your lateral of the two forearm bones. And again, it's at that proximal end. You're also going to find the two lips, the coronoid process, which is the inferior lip of the proximal end of the ulna, and the olecranon process, which is the superior lip. And of course, just below the coronoid process, you have what's called the ulnar tuberosity. So it's not just tuberosity, it's usually referred to as the ulnar tuberosity. Again, when the mouth side or the wrench side is facing straight up towards the ceiling, whatever surface is showing when you do that in that position, that will be the anterior border of your ulna. And in order to find position between right and left and make sure you know which one is right or left ulna, you put the trochlear notch in the olecranon process with the trochlear notch facing up. And of course, your styloid process is down at the distal end. And when you put it in the correct position with the right side or the left side, then whatever's facing up again is your anterior border. So again, if we look at this, you can see the bone in question, we're going along the pinky side. Here is our ulna. You don't see a lot of components from that anterior aspect of the proximal end, but again, here's our anterior border. Radial notch would be right here where the radius cozies in, and then this is the interosseous membrane. So the interosseous border would be this lateral aspect of the ulna that you see me pointing to with my mouse. When we go into the posterior side of things, again, we can see the olecranon process of the ulna fitting into the olecranon fossa of the humerus. You can see a small portion of the coronoid process and trochlear notch surrounding the trochlea. And again, you can see the posterior border and that interosseous membrane, again, on the lateral aspect of the ulna. All right, so right humerus in relation to the scapula, ulna, and radius. So again, if this is a right humerus, remember, for humeral determining right from left, humeral head always has to point medially, so in towards the body, and your olecranon process has to face posterior. So if that were lined up correctly, that should show you in this case that you have a right humerus, right scapula, right clavicle, right ulna, and right radius. All right, so articulations that are formed by the ulna and radius, you have two. You have the humeral ulnar joint and you have the humeral radial joint. So one is a lateral aspect joint made by the humerus and the radius, so radiohumeral or humeral radial, and then humeral ulnar, which is going to be the medial of the two joint processes. So the radius, of course, is our lateral forearm bone on the thumb side. The head, which is disc shaped, it has the fibrocartilage disc at the end of it, are on the proximal end. So while the ulnar head was at the distal end, radial head is at the proximal end. And just like all bones that we've talked about, with the exception of the humerus, which has two, the neck is on top of the head is on top of the neck, just like it is for us. So the head articulates with that little depressional end where you have the fibrocartilage disc with the capitulum. So it just kind of sort of has a little depression that holds it in place, but it's a very precocious holding in place, very similar to the glenohumeral joint. The radius is also held in place abutted up next to the ulna at that radial notch, and then held together the length of the shaft by the interosseous membrane. Remember, just like the ulna had an ulnar tuberosity just below the coronoid process, the radius has a radial tuberosity just below the neck of the radius. It also faces superior anterior. So the anterior surface of the radius, or the articular surface at the end of the radius on the thumb end, where it articulates with the capitulum, you also have a small articular space for the scaphoid and the lunate bone. So the two bones that are in the proximal row of four carpal bones closest to the thumb, right? So those will also articulate or at least hover over the distal end of the radius, opposite side of the head, which was up by the proximal end. All right, so looking at the radius again, you're going to have an ulnar notch now, just like it was for the ulna. The ulna had the radial notch at the proximal end of the bone. The radius has the ulnar notch at the distal end of the bone. So they are held in place both by the radial and ulnar notches on their respective bones, ulna and radius. And again, it's just a little depressional area, but the majority of those two bones being held together and allowing to pivot over the surface of each other is accomplished by the interosseous margin, which is filled, of course, with the interosseous membrane. So that membrane is loosely the hold that's really keeping those two bones articulated with one another. Again, the radius will have an anterior margin. That anterior margin is always on the same side as the radial tuberosity. So the ulna and radius are connected by that interosseous membrane. There is a proximal radial ulnar joint. That joint takes place right at the radial notch where it connects to the radial head. So radial notch of the ulna where it connects to the radial head. In terms of the distal joint, you have another radial ulnar joint that's going to be made by the ulnar notch and the radius. So you have two radial ulnar joints, a proximal and a distal. And then in the middle, again, they're held together by the interosseous membrane. So again, here would be your proximal radial ulnar joint right here. Here would be the distal radial ulnar joint right there. And then all of this membrane in between, interosseous membrane. So articulations that are formed between the radius and the ulna would be that proximal and distal radial ulnar joint. Also, you're going to have the glenohumeral joint, or sorry, not the glenohumeral, the humeral radial joint and humeral ulnar joint. So 4 joints total made between the radius and the ulna, 5 if you count the interosseous membrane connection. All right, so we'll end there. We'll pick up here in lecture on Wednesday and continue with bones of the skeleton of the hand.